sorry if I keep going in and out or get scratchy, so thanks for putting up with that. But today's lecture shouldn't take the whole time, so hopefully we can just kind of power through this. We can decide if we want to break later, but so there's less slides than the last time, but this material is kind of more straightforward. To me, it's more interesting because I'm an infectious diseases type person, so I like when we have organisms that we can target and that sort of thing. Like I feel like Monday's lecture was more of a lot more empiric there. You don't really know what we're targeting, but it's just sort of disease state. This is what we normally treat with, but today it's more like this type of bacteria is responsible for this. Usually, so this is what we treat with. So it seems to me this seems more straightforward, concrete. So hopefully it'll be better for you guys. So the topics we're going to talk about today: bacterial infections of the skin, psoriasis, and acne, vulgaris, as well as rosacea. So we'll start off with bacterial infections. There's many different types of infections. A lot of these are very similar to each other, but they might be named differently because of the depth of the infection. So, like impetigo and eczema are very similar. It just depends on the depth of the infection. And so we'll kind of go through those and how they're classified. And the treatment is kind of similar. So the causes of the bacterial skin infections are usually strep pyogenes or group A strep. A lot of times it's abbreviated as CAS for group A strep, or Staph aureus. So impetigo normally shows up as scattered vascular lesions. Historically, it was normally caused by group A strep. However, more recently has been Staph aureus that's primarily implicated in this disease. And so why is that important? Because we want to know what we can treat it with. We want to make sure that the antibiotic that we use is going to target that organism. So we want to get as narrow therapy as possible. We don't need to cover both organisms if we don't have to. Eczema is a chronic form of impetigo, and it affects a deeper layer of the skin. So it's usually like an ulcerated, deeper infection, and it usually has like crusted layers over top. And so this also can have gram-negative organisms, in particular Pseudomonas, or even fungal organisms. And so that's important because you might need to add coverage of antibacterials to cover those affected organisms. And then cellulitis, this is just infection of the skin and subcutaneous tissue. And so this can spread systemically, especially if it's not controlled. And it can develop from any type of wound. So if you have cuts, burns, punctures, any sort of trauma, anything that can reduce that barrier, I really hope this is how this works. Sorry. You guys have like antibacterial gel and stuff? Oh, but yeah, I'm sorry. I really apologize. I did get some on there. I've been like talking around on it. Okay, so you can get other reasons that you can be more predisposed to cellulitis, such as obesity, venous insufficiency, edema of lower extremities, so really anything that can alter the blood flow, that can allow those bacteria to really overgrow. And it depends on the type of bacteria too. So if it's an anaerobic organism that doesn't need that oxygen supply with that blood flow, then that's going to be more prevalent if you're having vascular insufficiency. So most commonly, group A strep and Staph aureus are the cause for cellulitis. And then some predisposing factors, like patients that are IV drug users, you might want to cover for Pseudomonas because that might be the causative agent. And then E. coli and Klebsiella, there's some other factors there, depending on where the patient was or what they were exposed to. Patients that have animal bites, we worry about Pasteurella in addition to group A strep. So, when you have an animal bite, you worry about what was in the animal's mouth as well as what's on your skin getting in. So you have to think about the mechanisms of the bacteria that are getting into that wound. It's erysipelas. This is a superficial form of cellulitis, so it's not as deep. It's more common in infants and children as well as the elderly. And it's also called St. Anthony's fire. It spreads rapidly. It's usually on the face and lower extremities, and it's like really red raised areas. And it's predominantly caused by staph pyogenes, or strep pyogenes. Pustular infections can be caused by irritations of the skin, such as shaving or waxing. So anytime you can cause any superficial cut in the skin, humid conditions, diabetes, can cause a lot of different types of cellulitis, or exclusion of hair follicles. So if you're not allowing them to breathe and get air, you can cause those exclusions. And then folliculitis, which is superficial infections of the hair follicles themselves, usually on the facial area, and Staph aureus is the most common bug that's implemented in these infections. In patients that have received long-term treatment for acne, you can have different organisms such as Klebsiella, Enterobacter, or Proteus. You may need to have different treatments available. So a lot of these different infections will have common organisms, so you really need to get a patient history to determine if there's other organisms that you might need to cover in addition to those that are commonly implicated. Furunculosis or carbunculosis, so furuncles or carbuncles. Staph aureus is usually involved the deeper areas of the skin, usually developing from folliculitis, and then developing into furuncles or carbuncles. Excuse me, I'm really sorry, guys. Have you guys all heard of necrotizing fasciitis? Like from the news, there was a girl like in Georgia that was declining and like fell off into the water and like cut her leg and had this like flesh-eating bacteria. So that's basically what the name implies, is that it's a flesh-eating bacteria. And so what it really it's an extremely serious infection. So patients need to be basically rushed to the operating room. And a lot of times need to have areas like cut out, debrided right away, as well as antibiotic therapy put on immediately, or else they can risk having amputation. And so you can get these from a lot of different things. So the girl that was dislining, we had a case where I did a rotation of a student, and we had two patients who like popped a pimple. Like one lady popped a pimple like on the back of her neck. Actually, she had her boyfriend pop her pimple on the back of her neck. And so what comes out sometimes goes back in. And so she actually had a necrotizing fasciitis in the neck, and so they had to keep taking tissue away. So a lot of times, a necrotizing fasciitis ends up in an amputation. So exactly. So what are you going to amputate there? So it's a very serious condition because there could be a lot of toxins produced. So the antibiotics that we choose sometimes don't necessarily target an organism, but they might target the toxin that the organism produces. So I don't know what all Kristen taught you with the antibiotic lecture, but clindamycin can mediate toxin production. And so it can mediate those toxins, not the production of them, but once they're produced, it can mediate those. So a lot of times we'll give clindamycin in addition to like penicillin if we know it's like a staph bug or like a strep, and then we use that for the toxin, not necessarily for the bug. So this is a very serious condition, and it can spread rapidly. So they can create these tracks and like move along the tracks and affect other areas really rapidly. And so that's why you debride that area and you make sure you get the margins around that area, or you might have to just amputate to stop all further spread. So this doctor gave a lecture on different types of infections. That was one he presented as a case, and like at the end it was like, moral of the story is no positive pimples, no white boyfriend, positive pimples either. But anyway, so again, life-threatening, if not diagnosed early, the mortality is high, especially for these patients. So a mortality rate of 20-30%, and it can approach 50% in those with vascular disease. This initial lesion is minor, so some of the patients don't even have an initial lesion, so it might just start under the skin and spread through there. So you have to worry if it's like really red and warm, you might be concerned for next step. It's usually monomicrobial in nature, usually strep pyogenes or Staph aureus, but it can be polymicrobial as well. This will be going over MRSA. You guys are probably all familiar with this. Resistant to all penicillins and most cephalosporins. You guys remember the one cephalosporin that covers MRSA? Apparently, Teflaro is the brand name. So MRSA can be community acquired or healthcare associated. So the treatment's a little different depending on what it is, if it's community or healthcare associated. It is challenging to treat. We have to use a lot more bigger gun antibiotics, those with more side effects. Some of them you can't treat orally, or some of them don't come orally, so you have to use IVs. So it's just a lot harder to treat in general. So this can occur in otherwise healthy individuals. A lot of it has to do with the individual's environmental conditions. So military personnel, athletes that are in close quarters. We see a lot of brothers and sisters coming in with infections because they like play together and they're touching each other a lot. So it spreads skin to skin contact. So that's something that we'll talk to our patients about if they are like living in close quarters. You know, it's one of the risk factors. So just kind of a pathophysiology on these bacterial skin disorders. So you guys are very familiar with pathophys of the skin, 3 different layers. So the infections can be classified by the depth. So we kind of talked about with the impetigo and echinacea. And there's normal flora on the skin. So you have bacteria all over. You guys probably did experiments in grade school or high school where you like floss your arm or floss, you know, inside your teeth, and you grew a bunch of different stuff because we have it everywhere. So if you get a break in your skin, you can get that bacteria in. So we want flora on us. We want bacteria on us because it keeps us healthy. But those can also cause infection because we see the sort of infections in those areas as well. So some people are colonized with MRSA, Staph aureus, in the nose. So we do a lot of tests in the hospital depending on the patient that comes in or whether they are placed in a certain spot to see if they have colonization. So we don't spread that from patient. And then some chronic conditions can predispose patients to skin infection. So if you have a dialysis patient that has, a fistula, or if they have some sort of access site decline, diabetes, and because of your vasculature, can predispose you to cellulitis. So these are types of things to think about when taking a history from the patient as well. So biggest things for treatment, kind of like the last lecture, good hygiene, avoiding irritants. So if there's something that's causing this, avoid it. And then wound care, proper wound care is important. If you do break that barrier, making sure that you take proper precautions. Adjuvant therapy makes it warm soap, elevation of extremities, and then IND can be done with more invasive infections. So we can take patients to the OR and then kind of clean out that area to prevent it from becoming infected even more or spreading into the blood. We can start empiric therapy if we think that patient's infected, or if the area looks really infected. So we would want to cover for group A strep and Staph aureus, unless we have a culture. So a lot of times we're not going to get a culture from these patients, especially like in cellulitis cases. Like you don't really have anything to culture. If you swab their leg, you're going to get everything that's normal on their leg. We're not going to cut them open just to get a culture right to the surface. So unless you have some like draining wound that we're going to drain anyway, then we might get a culture from that. But we'll get cultures like in surgery if they do a surgical drain. But if they don't do that, then we usually do So the goals of therapy are pretty straightforward. Cure the infection, prevent it from worsening, minimize scarring, prevent recurrence, and also prevent spreading when people don't spread somewhere else. I feel like I'm not supposed to make that.
Do you want some cough drops?
I actually have some. I guess
Okay.
I can use them.
I was gonna say I have some.
I'll take the hit.
Oh, I was just trying to be helpful. Sorry.
I haven't been like this bad all day. I don't. What? Oh, okay. Blame the building. So most infections do resolve within 10 to 14 days with or without therapy. So a lot of times we don't treat unless the patient's showing signs of infection. And so, you know, if you have a cut and it looks red for a while, you're not going to treat. You're not going to go to the doctor every time. So you want to make sure that it actually looks infected. It's running, swelling. Then we might need to treat the patient. All right, so what are our agents that we use for treatment? The first generation cephalosporins include Keflex and Duracell. Generics are on there as well. Second generation cephalosporins are listed there as well. A lot of times we'll use the first generation cephalosporins. They have good coverage of these agents, and they're cheaper. They're fairly cheap. Keflex is really cheap. So that's like a major factor for a lot of patients is cost for the antibiotics as well. Third generation cephalosporins. So what do you guys remember about cephalosporins and the generations? Like going from low to high, what do you gain and what do you lose as far as coverage? Good. So you gain gram-negative and you lose. You don't like totally go down on gram-positive. You still remain some gram-positive coverage, that you get less. You get less gram-positive coverage and it's less strong coverage. We want to use first generation cephalosporins. We're covering these through strep and Staph aureus infections more readily than like a third generation cephalosporin, unless we're trying to cover for those gram-negative organisms in like a special population. If they're at risk for other organisms as well. You can use macrolides as well, erythromycin, azithromycin, and clarithromycin, especially for penicillin allergic patients. One thing to note with these is there's a lot of drug interactions. There's like QTC interval elongation. So for patients that might be on like amiodarone, you might not want to prescribe these agents. So there's a lot of things to factor in for our treatment for these patients. Clindamycin we use a lot in like pediatric patients. If we're considering MRSA as an agent, we can cover the community-acquired MRSA. And it's a good alternative for patients that are allergic to penicillin. One of the side effects of clindamycin that you probably already learned is antibiotic-associated fluctuating difficile diarrhea. And so this is less common in peds than it is in adults. We don't really know why, but a lot of adults that are on clindamycin will get diarrhea. We don't use it as much as in adults. Fluoroquinolones also have good staph and strep coverage, so they'll use these a lot and they're once a day. So it's pretty easy to dose as far as Levocin once a day, Ciprofloxacin twice a day. And so you see Levocin used a lot as well. So this can be used for more serious infections because it has added coverage. So you're going to get your gram-negative coverage as well. So if we have patients with more comorbidities, then you might want to escalate to a fluoroquinolone. So now we're kind of getting into our bigger gun agents. So vancomycin, daptomycin, linezolid, and tigecycline will all cover for MRSA. So these agents are reserved for those patients that have risk factors for MRSA, so we know that their infection is caused by MRSA. They have a history of MRSA as well, and so we want to make sure we're covering for that. So we'll save those agents for those types of patients. So out of this list, the only thing that comes orally to treat for a systemic infection is linezolid. So vanc comes orally, as we know, to treat for C. diff, but it doesn't get absorbed from the gut, which is why we use it locally for C. diff diarrhea. But the rest of them, but only linezolid oral. So the rest of them, the patient would have to be in the hospital or receiving home health prevention and disease center. So those types of things are important to think about as well. Trimethoprim, palmitoxazole, or Bactrim, another brand name Cetra. We use for treatment of MRSA as well, but it's not reliable for group-based stress. It doesn't have good stress coverage. So you need to be certain the diagnosis is staph and not stress. And so if you want to use Bactrim, you need to make sure it's staph, or else sometimes we'll use Bactrim plus Teflex to get that added coverage. Topical agents can be used with first-line or adjuvant therapy, kind of depending on the disease state. Bactroban ointment is effective against MRSA, and so a lot of times we'll use that topically over like a cellulitis if they know it's MRSA and they're having like some wound dressings. They might do it with dressing changes twice a day, but it is a topical treatment to get more localized control there. And then you can also use gentamicin ointments or creams if you're trying to cover for group-based stress, capillaritis, or pseudomonas especially. All right. So for impetigo or emphysema, first-line therapy, if it's minor, it's topical mupirocin or Bactroban. You can use a broad-spectrum penicillin or first-generation cephalosporin. And the treatment for this is about 7 to 10 days. It's a pretty short course of therapy. For penicillin allergic patients, we've kind of talked about therapy. We can kind of go back to the slides to see where penicillin allergic patients therapy kind of comes in. But clindamycin and then our macrolides are pretty good alternatives for these patients. So sometimes agents might need to be used for longer therapy, and some patients may need IV therapy. For eczema, because as we talked about, it's a deeper infection. It might have some ulceration as well. We might need that longer therapy than impetigo. If we suspect pseudomonas, we might want to do Cipro. So we know that Cipro is one of our tools for the ones that covers the pseudomonas. We could add that therapy. And then we could consider IV therapy if the patient's not responding to oral, unable to take oral or tolerate it, or if they're hospitalized, and again, they can start off on IV therapy for a couple days if needed. But a lot of these drugs have good absorption, especially the fluoroquinolones. They have pretty close to 100%, 90 to 100% absorption, so there's no need to start with IV therapy. All right, so for cellulitis, first-line therapy always requires systemic therapy. Systemic doesn't mean IV. It means, getting all over your body. So that means oral or IV. And so for mild, this could be outpatient oral antibiotics, or it could be inpatient IV therapy if it's severe, or inpatient oral therapy if you really want to make sure you're monitoring the patient. We would use a broad-spectrum penicillin or first-generation cephalosporin. And the treatment is usually 10 to 14 days, and this is baseline clinical response. So if the patient's really improving by day 3, 10 days would be appropriate. If the patient takes till day 5 or 7 to start responding, then 14 days is probably more appropriate. And it kind of depends on comorbidities as well. If for a diabetic patient, we might take longer than a patient with no comorbidities that just happen to get cellulitis. Alternatives, again, are the same, especially for penicillin allergic patients. And then if we suspect MRSA, we would add Bactrim or clindamycin or Zyvox. Zyvox is probably one of the preferred agents for these patients because it's easy to take, has good transition to oral therapy, and the side effects are fairly benign, and there's good patient assistance programs. It's fairly expensive, which is a big problem, but we have had good luck with patient assistance programs. And then if we have no response to initial course of therapy, there are patients showing like signs and symptoms of systemic illness, so like if they're having low blood pressure or high heart rate, sort of septic picture based on their cellulitis, then we would start IV therapy. So for our different pustular infections, the first line therapy is topical. They help, but they usually need systemic topical therapy if it's a mild form, but they usually need systemic therapy. You can also give an oral antibiotic. You would choose an antistaphylococcal agent, so dicoxicillin, cephalexin, or clindamycin are good agents. If you do suspect pseudomonas, you could choose an anti-pseudomonal penicillin. So which one is that? What was that? Zosyn, perfect. So that's our anti-pseudomonal penicillin is Zosyn. Good. What about Unison? Does that cover for pseudomonas? Ampicillin sulbactam. Go to your gut. No. It doesn't. No. Unison is very similar to Zosyn in its coverage, but it does not cover for pseudomonas. So it lacks that. So we use that a lot in patients that have like aspiration pneumonia, and we want to cover all of our gram-positives, gram-negatives, anaerobes from your mouth, because that's why you're aspirated. We're not worried about pseudomonas, like it's not a healthcare-associated pneumonia. So it decreases the coverage, so we don't need to cover for everything if they don't have it. So, all right. And then second line therapy, you can treat if patients have colonization, you can treat it with Bactroban nasal with their colonized MRSA. You can give them a course of Bactroban nasal, or they can do different chlorhexidine washes. They can do baths. Or they may require systemic therapy for severe infections. Again, with all of these, they're very similar to here as far as treatment. So for necrotizing fasciitis, we kind of already went over this. Aggressive surgical intervention is usually required and immediately. The empiric antibiotic therapy just depends on what you think the causative organism is. There's a lot of different combinations there. A lot of times we'll also see like penicillin clindamycin or vancomycin clindamycin. So a lot of times when you see vancomycin clinda, they're like, why do we need both of these? And so you usually think maybe it's neck fat or a toxin producing agent is implicated when there's both of those. We don't really need to ever cover agent. And then if we do have a penicillin allergic patient, we would substitute vanc for the ampicillin to make sure we're covered for that dose. And if we suspect resistant organisms, again like MRSA, we want to make sure we're covering that. We would substitute the vanc for the ampicillin as well. And then once culture and sensitivity results come back, we want to de-escalate therapy as soon as possible. If we do get cultures from that, it kind of goes day by day. We'll start getting cultures. We'll know what the bug looks like, so we can kind of tailor therapy with that. We still have to stay broad, and then they'll tell you what the organism is and what antibiotics it's sensitive to. So it's kind of a day by day, stepwise therapy of getting the patient the most therapy so that they don't have adverse reactions to that. So how do we monitor these patients? So it depends on what they have. So with impetigo, we really only see these patients back if their condition doesn't resolve. So usually we can give them their therapy and they can go home. With ectophila, because it's such a deep infection, we want to have close follow-up. We want to make sure we monitor them and have them come back at least for one follow-up appointment, if not more. For folliculitis, it's often recurrent and chronic. And so we want to emphasize prevention. And with carbuncles, there's risk of secondary infection, so we want to make sure there's close follow-up after their initial treatment for that. And then for cellulitis, we want to make sure that we have close follow-up because we want to make sure they clear their infection, if their duration of therapy was appropriate, and that they've done everything that they need. We want to make sure there's no other underlying causes that's causing this. All right, so what do we tell our patients? Biggest thing, complete their full course of therapy. They may feel better, their redness may go away, they may think they look better. After 7 days, they don't want to complete 10 to 14 days of therapy, but it's really important that they complete their course. This may predispose patients to secondary infections, like being on antibiotics may predispose you to predispose women to yeast infections. So these are some things that they can even warn people about too. And then thrush as well can develop in your mouth. We talked about thrush last week. For patients that are on antibiotics and you are killing a lot of the bacteria, then yeast can kind of overgrow. So that's the same thing with yeast infections as well. And then with all patients on antibiotics, kind of a PSA can decrease oral contraceptives. So female patients who want to counsel that they need to use a backup form of very birth control while they're on antibiotics for their therapy. And some people say for next week after, and some people say for the next day. So that's kind of your comfort level as far as what you want to tell your patients. But I usually say for at least a week after therapy. Some of these can be transmitted skin to skin, like a Chicago, and so you want to make sure they're telling that patients, especially if they're in like close quarters with siblings, if they're at daycare, or older patients like in the military, that's the close contact can cause transmission to other people. And then when to seek further treatment, so you prescribe this antibiotic, you're going to send them home, but when should they call back, or when should they go to their go through I guess you'd probably do their PCT, but if they have fever, increased erythema, any shrieking, especially with that next app, like I said, they can form those like channels to really kind of work their way down really fast, or if they still looking away. Alright, so moving along into psoriasis. So this is more of an autoimmune disorder characterized by exacerbations and remission. And so it's painful and itching, has stinging, cracking, and bleeding lesions. So this can be both very painful and patients are kind of like embarrassed by the different lesions that they have. It affects 2 to 3% of the U.S. population, and a lot of those patients, like over a third of these patients, have a family history of it. And so there's a genetic component as well. And 10% of these patients will develop a psoriatic arthritis that goes along with it. There's 2 different age groups that have a peak of onset, so late teenage to early 20s, and then late 50s to 60s usually sees the onset of the psoriatic breakout. It's more common in patients in colder climates, and the definitive cause is really unknown, but they know it's an abnormal epidermal cell cycle, so there's something going wrong with that. There's predisposing hereditary factors, and then some triggers such as rubbing, scratching, histories of sunburn, infections, stress, and then some medications as well. So the pathophysiology behind it, again, we don't know the known cause, but the cause is driven by abnormally activated helper T cells, and so there's specific interactions with antigen-presenting cells and non-specific super-antigen interactions. So this is the infection part of it. So the antigen-presenting cells require co-stimulation as well, because psoriatic T cells produce different cytokines, including interleukin-2, necrosis factor alpha, and interferon gamma. And so these cytokines attract and activate neutrophils, which are responsible for the inflammation. So there's a lot going on, but basically they're immune systems. So it's an autoimmune process. And they complement what products and trying, and they also recruit neutrophils. So that's a lot of information. Don't need to know the specifics, but it's an autoimmune disorder. We kind of know what's going on, but you can see that when we talk about the therapy, how it's targeted, it will be very evident in the pathophysiology. So the biggest treatment is avoid precipitating factors like those triggers, rubbing, itching, scratching, sunburn. There's certain medications that can trigger that. And then there's different treatment modalities. You can do topical treatment, phototherapy, or systemic agents. And we want to assess the involvement. So if the involvement is pretty localized, if it's less than 10% of your body, then we can use topical medication. But if it's generalized, then we need to go on to systemic therapy or phototherapy. So that's more than the 10%. The goals of therapy, pretty straightforward. We want to make sure we reduce the plaque size and thickness of the plaque, and then decrease the itchiness for the patient. So this is like the main complaint of the patient. So cosmetic, it's really not, good to look at. They don't like it, but also it's like so itchy that it really drives them crazy. We want to achieve remission in these patients as far as the plaque, and then minimize adverse effects from the treatment. So this is a long-term disease requiring maintenance therapy for most all of the patients. So there's 3 different phases: clearing, transitional, and maintenance. And so we'll kind of walk through those. So the topical agents that we can use include emollients. So we can have lotions, creams, or ointments. So these hydrate the layer of the skin, the stratum corneum, and they decrease water evaporation and just soften the area. And then topical corticosteroids are really the foundation of the treatment, and they decrease the erythema, the itching, and the scaling. And then, as we talked about on Monday, one of the major things that we use topical corticosteroids for is vasoconstriction, and so that's what it causes in that area as well. So now we'll kind of walk through the other topical agents that can be used. So coal tar is a polycyclic hydrocarbon formed from coal. So it works by suppressing DNA synthesis, and it has anti-inflammatory and antipyretic properties as well. There's a lot of different formulations for the patients, so you can get these in ointments, gels, different baths, or even a shampoo. And this is used as initial therapy. And it's applied usually overnight because there's a strong odor associated with it, and it's very slow. Like, it's not going to magically cure your psoriasis overnight, and so it's not usually used like on a inpatient basis. This would be something that would be like outpatient therapy for our patients. It does have, as we talked about, a strong odor. It can stain the clothes and the skin, and our patients can be susceptible to sun exposure, so more photosensitive, so we want to make sure to supplement on proper sun exposure care. Folliculitis can develop, which can require discontinuation of this treatment. Another agent, anthralin. This is a coal tar derivative. Similar mechanism of action, obviously, and it decreases epidermal proliferation. And so the dosing is time consuming. So you have to let it sit for 30 to 60 minutes. And so again, slow onset of action, it's a coal tar derivative, slow time to response. And we don't want to use it with an acute psoriasis outbreak. It's more for like a chronic patient. A patient with severe inflammation. It can cause irritation of the unaffected skin. So we want to apply emollient to healthy skin around the psoriatic region, and then apply this to, as localized as possible to the lesion. It can stain a lot of our different surfaces, including our clothes, and even like the sink. And so we want to try to minimize the amount of exposure to that as possible. So you can have patients use like something you'll throw away, like a paper towel or something with like skin off before you rinse it off. So calcipotriene, Jovanac, this is a vitamin D analog, and this is used for mild to moderate psoriasis. So this reduces cell proliferation by binding to receptors in the epidermal keratinocytes. So we talked about keratin cells on Monday to suppress their dead layer of skin. And so it also has an anti-inflammatory effect. So So a lot of these agents are going to have an anti-inflammatory effect because that's one of the major problems in patients with psoriasis is the inflammation and itching. So it's effective for long-term and maintenance therapy. So it may be rotated with topical steroids. So sometimes we'll have patients on these rotations as far as use this for so many days a week and then use this for so many days a week. And so the dosing is applying twice daily for 6 to 8 weeks, and responses are seen in about 2 to 4 weeks. So that's something to tell your patients. You're not going to see results tomorrow. You might not see a result by the end of the week, but in 2 to 4 weeks, you should be seeing a result. The max dose is 100 grams a week. So some of these drugs too, especially we talked about with corticosteroids, how they have different potencies. You want to start low. Some of these drugs as well have max doses because there's a strong targeted therapy. So I want to make sure that you're aware of those when prescribing. We want to make sure we avoid treating patients with high calcium levels and avoiding patients with high levels of vitamin D. It can cause dry skin, peeling, and rash. And so calcium patients will notify these symptoms and then follow up if needed if there's any signs of that. Tazarotene, or Tazarac, this is a topical retinoid used for mild to moderate psoriasis as well. And this drug promotes longer remission, so longer time between flare-ups in the psoriatic region. So it normalizes epidermal differentiation, and it can help with these plaques to reduce the size and the proliferation and the building up of them. And then it also decreases inflammation and skin cells. These kind of decreases from the different agents. So this is applied once daily. You should be seeing improvement within a week, and then you should see clearing noted in 8 weeks. And so again, it is a long-term type therapy for these patients. It's not going to be like a quick cure. So we're going to start talking about a lot of these retinoid products. And so the big thing with these is that they're contraindicated in pregnancy. And so there's a lot of hoops that patients have to jump through to get these medications, and there's a lot of hoops that pharmacies have to go through before they can even start the medication to the patient. And we'll kind of talk about that. I think one of the other drugs we like walk through what the patients have to do. All right, so some of the adverse effects include pruritus, erythema, and mild to moderate burning. So if this is something that the patient can't tolerate, then we can try to remove it. And then the psoriasis may get worse before it improves. And so if initially the patient doesn't feel like it's getting better, but it's getting worse, then you might say, let's try it for a few more days, maybe the rest of the week, and see if it starts changing after that. This should be improvement. Obviously avoid ingestion with any of these agents, and avoid use of other medications that may cause photosensitivity or other irritants because it's so irritating itself. Right. So epinephrine is psoriasis. This is a systemic retinoid used for long-term psoriasis therapy. So its mechanism of action is the same as the drug that we talked about before, and it's dosed once daily until the lesions are clear. So, contraindication on this drug, pregnancy and lactation, same with all the other retinoid therapies. You can't donate blood for 3 years following therapy. So, very strict on that to remain in your system, like any drugs to remain in your system for a long time. But you can't donate blood for 3 years. It's kind of crazy. I thought that was weird. But they're just being very safe about a lot of these drugs because what if a pregnant woman got that blood that was donated by a patient? So it's not that you'll have detectable levels or anything for 3 years. You probably wouldn't have them for 3 weeks, but I think it's more of a safety thing. Adverse effects include lipid elevation and abnormal LFTs. So once you start getting into systemic therapy does skin peeling, pruritus, dry skin, and dry mouth. A lot of these patients who have supportive therapy to help with the patients if they're unable to tolerate that. There are a lot of drug interactions with this medication, so that's something that you should look at for prescribing if they're on methotrexate for another reason, like rheumatoid arthritis or something. A lot of times you just have a lot of these combinations of these things. And then ethanol prolongs the teratogenic effect, so we try to couple patients to avoid alcohol while on the therapy, and then after they're done with therapy as well. So methotrexate is another systemic agent that's used to treat generalized psoriasis. And so it inhibits folic acid reductase and results in inhibition of cellular replication. And so it targets the most rapidly dividing cells. So it doesn't really differentiate between, the psoriatic cells versus other cells in your body, like your stomach, and so there's a lot of side effects to this medication. Dosing with this is very important. When we put in methotrexate in the pharmacy, like a huge alert comes up, and we have to make sure we match the indication with the dosing. So I don't know if it comes up on the provider side when you guys order it, but based on the indication, there's specific dosing because daily dosing at these levels can cause fatalities in patients. So it's very important that the dosing is right, especially for this drug. You want to start low and titrate up. For these patients, they'll probably be they'll start on say Sunday and take a certain amount, whatever their dose is, and then the next Sunday, you'll either take that dose or titrate up. You'll get a titration schedule, but they'll be on a certain day of the week that they'll take their meds every single week. And then they'll also be on folic acid daily on non-treatment days, so we'll take that the other 6 days of the week. Because it inhibits folic acid reductase, so we're inhibiting that pathway. We want to make sure we're supplementing the patient and getting them a little folic acid reduction. Again, contraindicated in pregnancy and lactation, and a lot of adverse effects because of its non-specific targeting. We're going to get a lot of adverse effects, especially in systems that have rapidly dividing cells. Alright, so the cyclosporin is another agent we can use. It promotes, it's one of our immunosuppressive agents. It promotes rapid remission. So it's used for short-term treatment of exacerbation. And it suppresses cell-mediated immune reactions and humoral immunity. And it inhibits production of IL-2, which causes T-cell proliferation. So the max dose is 2 to 5 kilograms per kilogram per day. So there's some standard different types of capsules that we have. So they come in 25 or 100 milligrams. Usually dose your patient based on, you'll find their dose, but make sure you don't go over that. Contraindicated in pregnancy and lactation, again. And then you want to use caution in patients with impaired renal function. I've seen a lot of patients that have had cyclosporin-induced nephrotoxicity from different reasons. They've been on it for, type of psoriasis or something else, and have ended up with nephrotoxicity. You want to make sure that you're monitoring renal function closely. So even in those patients, you can see it and then stop therapy early. Adverse effects include tremor, visible hyperplasia, GI upset, hypertension, and nephrotoxicity, as we talked about. Once you take the patient off the medication, the leaving can occur within days or weeks. We usually return with worse symptoms. So we want to make sure that once we take the patient off, that we're monitoring for those return of symptoms, and they might need to be on a long-term suppressive therapy after that. Do you guys want to take a break before we go on to the next section? I heard more keep going, so I heard a break. Keep going. Okay. All right. So we have like 30 slides left. We're more than halfway done. And so it's 3:50. I think we can get out of here. Okay. So biologic therapy. Yeah.
Just a question. You have all these drug names, and then you have them in parentheses. The ones in parentheses are the brand names, right?
Correct.
And we just need to know the generics.
If I put something on the test, I'll put both.
Okay.
But yeah, I work in generic names, but so I'll put both. If I do. All right. So biologic therapies, we use these because they target T-cell mediated immune response, and they have anti-inflammatory effects through those 4 different mechanisms. And so we basically want to alter the immune mediated response. That's the ultimate goal of this therapy. One thing before we start biologic therapy, we always need to test for TB in these patients because we can exacerbate tuberculosis in these patients because we're messing with their immune system. And so that's something that we always want to test for in patients before we start any type of or some types of biologic therapy. So it's very prominent in the package insert before we start these medications. So Intercept or Enbrel is used for treatment of moderate to severe. It contains human CNS receptors, so it binds and inhibits that DNA cytokines that help regulate the immune response. So it's dosed twice weekly for 3 months, and then weekly. And it requires 2 injections for each dose, so that's not really fun for the patient, but it's only twice weekly. And it's contraindicated with live vaccines. So if you have a patient that needs to get a live vaccine for some reason, you need to get that prior to starting this therapy. So it's usually an acute need for therapy. So if a patient needs a live vaccine for some reason, then we want to make sure that they get that prior to starting this. Adverse effects include infection. So infection is very important with these biologic therapies. Something you probably need to know like 2 weeks from now because you're altering the immune system. And so you're at an increased risk for infection. We saw a patient that had a bunch of these different biologic therapies for rheumatoid arthritis and then went in for a bowel surgery and had some disease in her bowel, and then like her whole gut was just ruined because she had been on all these biologic therapies, she got on steroids, and so her immune system was just tanked, and then she went into this major abdominal surgery. And so there's a lot of things to think about. I mean, she needed the surgery, but then she also had that weakened immune system going into it. So it's a risk benefit thing they had to take, but doing well now, but there was a hard time after surgery. So again, increased risk for infection, injection site pain. You're going to have that with any injectable medication. Localized erythema and rash, especially in the area of injection. Upper respiratory tract infections, that's going to be very common in a lot of these, especially those that reduce the immune system function, and then abdominal pain and vomiting. I don't really know how that's associated with it, but a lot of times if you see these in enough patients through the trials, it's kind of kept on. So, like I said, with the live vaccines, you want to make sure you give them at least 2 weeks before, 3 months after treatment. So it's just something that we need to counsel patients on, make sure they avoid. So infliximab or Remicade, very popular biologic agent for psoriasis, rheumatoid arthritis, monoclonal antibody that targets TNF-alpha. So we give this infusion every 8 weeks, so it's definitely a lot more patient-friendly as far as administration. Contraindications, patients with heart failure, and then again, the live vaccine. Very similar adverse effects in infection, headache, GI upset, all of those. I'm not going to read those for you. And then immunosuppression medications can increase the risk of infection. Pretty intuitive. You're giving an immune modulator, and if you give an immunosuppressant, so you're compromising the immune system in 2 different ways. So that's pretty obvious. So adalimumab or Humira is kind of becoming a new hot item on the market. It's increasing the FDA approval indications. They're coming out with new studies and getting it approved for a lot of different indications. We'll probably see a lot more use of it in the near future. So this can be used to reduce signs and symptoms of active arthritis and psoriatic arthritis. And so it is a recombinant humanized monoclonal antibody, and it binds to the TNF alpha. So again, we talked about the mechanisms of action for psoriasis and why we thought it was what it was caused from. So you can kind of see how these agents are acting against that TNF component, especially. So this is a subcutaneous injection given weekly with a one-time loading dose. So a lot of times we'll give these to the patients, and then they can show that they know how to give them, and we can give them to them to take home. It's like a pen injection that they can give themselves then. Again, contraindicated with live vaccines, adverse effects include headache, injection site reactions, nausea, and rash. Pretty non-specific. Same comment about immunosuppressant medication. So alpha-cept, this mechanism of action again is a monoclonal antibody. It inhibits LFA3-CD2 interaction. That's not important to you guys as far as like what that is and where that is on the cell surface, but it also inhibits lymphocyte activation, so that's kind of more of the component that you can think about as far as the immune response. And so it's an IM injection once weekly for 12 weeks. And then we must monitor the patient's CD4 and T cell count during this time because we want to make sure that they don't go too low. And it's contraindicated in patients with HIV. That's pretty obvious because they might have a low CD4 count already. We don't want to push them even lower. Adverse effects are there, again, pretty non-specific, cough, nausea, chills, infection, injection site reaction, which is common among all these agents. So in selecting therapy for patients with psoriasis, if it's mild to moderate, again, less than 10% of the body's surface area, it can be treated by a PCP, in outpatient therapy, where if it's more generalized and you might be taking systemic therapy, then we might refer to a dermatologist for either phototherapy or our systemic therapy agents that we just talked about. And so first-line therapy would be moisturizers or topical corticosteroids. If those don't help with the patient, then we can move on to usually topical steroids to maintain remission, and then taper steroids, or adding that vitamin D analog that we talked about. We already talked about referring to the dermatologist. And then our last section, so acne vulgaris and rosacea. All right, so acne vulgaris affects up to about 90% of teenagers and 30 to 50% of adult patients. Very embarrassing. High school years are hard enough. And then you have teenagers with acne. So it begins about 1 to 2 years before the onset of puberty when androgen production increases. And so this can cause an increase in sebum production. So, and this just kind of clogs up the follicle and produces the blackheads and whiteheads, so that's the open and closed chromosomes. And then Propionibacterium acne is normal flora in the follicle. So the bacteria is not necessarily causing